And good afternoon, everyone. Welcome to a fire question interview with a healthcare professional. I'm looking out the window at the moment. It is scorching out there. Lucky enough, we've got the really nice weather to come to Essex today. And today I've got a pain doctor with me today called Deepak. Deepak, would you like to introduce yourself? Can you tell the viewers what you do?
Yeah, thank you, Pete. Thank you for having me on your program there. It's been really good to sort of catch up with you finally. So my name is Deepak Ravindran. I am one of the pain management consultants, and I'm the lead for the Department of Pain Medicine at the Royal Berkshire Hospital in Reading, in very leafy Berkshire and the home counties. I'm also one of the main consultants to a kind of community pain service that we have here, which has been nationally recognized and awarded, called the Integrated Pain and Spinal Service, which is aiming to capture the best of self-management and patient-focused pain management in the United Kingdom.
That sounds fantastic. I'll tell you, I like the idea of that. I don't hear a lot of that going on. I hear a lot of treatment-focused stuff, but it sounds like you've got a good handle on it. Deepak, I know you're very tight for time today, so I'm going to use that well-known phrase now that you seem to use. I'm going to be mindful that we're going to move straight on to the question. So, question one is, what attracted you to work with people who live with persistent pain?
Well, my background as a doctor is in the subspecialty of anesthetics and pain management, and I've been doing that for now 20 years now. I've trained in both India and in the UK, and while as an anesthetist, I could provide them, very comprehensive pain relief. I actually could get them off to sleep, no doubt about that. But and they would be pain-free when they wake up as well, with all the fancy techniques that I had, the epidurals, the spinals, the general anesthetic. But when you're left with patients, I kept wondering, and I was very attracted to the fact that there is such a big number of people. And, from the studies we had last year, 28 million of the UK population are left with persistent pain. And realistically, we sometimes don't fully understand why that happens and why does it happen to some people, and what can be done to prevent it, and therefore what can be done to treat it. And that's been kind of the focus of my research and the clinical side, especially in a condition like fibromyalgia, which is one of my interests, to actually find out what to do, what can I do to help these patients. And if I can't cure them, what else can I provide in terms of treatment strategies, right from what can they do for themselves to what can we do to help them along the way.
I know, and it's the one thing I'm always promoting is what can people do for themselves? I was stuck like many people, but it is possible. If I can do it, I know other people can do it.
Exactly.
Let's move on to the question two. So, what do you say to patients? Now I know there's a lot of them out there. Like they email me and they say, "What can you? I want a quick fix." So, what do you say to patients who come to you and they're saying to you, "Look, doc, give me a quick fix"? What do you say to them? Especially if they're living with persistent pain.
Well, I get that. I think every clinic I have one or two patients at least who come with that objective in mind, because unwittingly, that's what they've been told by the other healthcare professional, that, go to the pain clinic, they will sort you out with an injection. And often the first 15, 20 minutes of my consultation is actually in trying to, separate it and actually say, what is it that I can possibly fix? But more importantly, what is their understanding of the pain, and what have they done to manage it? Or are they just being very passive about what somebody else is going to do for them? So trying to unpick that and then come up with a plan that kind of marries up with what I can do with what they can possibly take away from the treatment, whether it's a drug, whether it's an injection, whether it's a psychology-based strategy, whether it's just education itself. That's what I try to say. I don't think there is a quick fix in pain management. I think you have to combine elements of the biology the psychology, and then the social aspect of being the human being that they are.
Yeah. I always say to people with pain, it's there isn't one just thing. It's you have to have different elements involved.
Yeah,
And
exactly.
but you know, the work is done by the person, really. You know.
Absolutely. Absolutely. I think that is the thing that is coming out even from the research.
Mm-hmm. Okay, so we're going to move on to question 3. This is quite an interesting one I quite like, and is so when people come to see you, you know, I don't think sometimes, as I back in the day when I had back pain and other bits and pains and whatnot, I don't think I was the best prepared person to when I saw the GP or consultant, etc. So, what would be what are the 2 or 3 best questions patients can ask you when they attend your appointment?
That's a very good question, Pete, and I think it's good that you brought it up. And I saw some of the other sort of times when you did these with other professionals as well. And I have a common theme as well when it comes to patients who come and speak to me, who come along and tell me, and I wish they probably would ask me. And it's surprising, a lot of them do ask at least one out of these 4 or 5 questions, and you've brought up 3 of them. Kind of probably my first point is I'd like them to ask me, can you tell me, Dr. Ravindran, what are the various treatment options I have for me now that I'm sitting in front of you? What can I do to look after this pain? But more importantly, what is out there? Most of the time, they come along saying, well, what drug or what injection you're going to give me? So the second question I want them to ask me is, what are the benefits? What are the side effects for this medication or for this injection? And if it doesn't work, what can I do? And to make it work the best, what else can I do to give it the maximum benefit? You know, if I'm going to give them a facet joint injection, are they going to have an exercise regime? Are they going to follow a good dietary pattern? Are they going to stretch appropriately to make sure that the physio is done after the injection to maximize the benefit of the injection? The third question I'd like them to probably ask is, what else can I try for this pain? If what you're going to give me has only a percentage relief, what else can I do in addition to what you're giving me? That is the one question which I wish they'd ask more, because as I said in the earlier question, they are still a bit passive. I think that's partly our fault of the doctors and the GPs and everyone around. We expect them to just automatically follow what we tell them rather than them making a decision on what else can they do to complement what we're doing.
Yeah. I think it's what you know, it's a partnership, isn't it? You know, I've been using this analogy recently where, you know, I think the person with pain has to, you know, I say to them, you know, when I'm doing my workshops, say, how do you learn to drive? Where did you sit, in the driving seat or the passenger seat? You know, and they say, well, I was in the driving seat. Well, why was you there? You know, well, I had to learn. You know, and that's where you, not in the driving seat at the moment, you're in the passenger seat. You need to get yourself back in the driving seat with the help of the pain doctor or healthcare professional and let them be the guide, you know. Excellent.
Yeah.
Well done.
And if you're lucky to have a chauffeur to take you around all the time, all your life, you're good. But most of us aren't, you know. The NHS
I'll tell you what, mate,
they can give everyone a chauffeured car.
Hey, Deepak, I won the lottery last week. I won £2.90. So it made, you know, perhaps if I won a couple of million, I might get a chauffeur, I don't know. But no, I like driving myself around. Okay,
That's
so...
good. And your Harley.
Yeah. Okay, we're really both really. This is really good. Now, we're both on social media, and I know you're very active on social media and the stuff that you're tweeting, etc. I'm not sure if you're on Facebook, but I don't know if you know, but I've started up a dedicated closed pain toolkit group now. Where there's a lot of, it's surprised me really, the amount of activity that's actually, you know, people talking amongst themselves, etc. So all this social media, I think, can be a benefit. So the question for you is, question 4 is, do you think social media, i.e. Twitter, Facebook and all the others and apps, could they be useful to promote pain self-management?
I think that is a very, very topical and a very important question. My answer would be simply yes. Uh, what I think doctors probably need to find is the right mix of the privacy to ensure that you don't give too much treatment suggestions, then you risk confusing the patients. From the doctor's side, I think that is a risk which doctors have to evaluate on how they want to give advice or suggestions on Twitter. But once they have navigated that, then I think Twitter and Facebook has been a revelation for me in terms of how I now get my information about various advances in pain management and how much I tweet about it. And so if I were to come into contact, so there are two separate things. One is, can Twitter be useful in how I give pain management information to patients? And like yourself, if there are expert patients on Twitter who are able to bring the best of evidence as well as self-management into that sphere, then yes, I'll encourage them. But if they are going to come with quasi-scientific stuff, then I would be careful enough to point it out. Is it true or not? It can be sensationalistic. That's what 270 words on Twitter allows you to be. But we need to just make sure that we get the balance right in how we use Twitter and Facebook. I mean, I'm on your Toolkit group, and I think that's a great place for getting that information. I take bits of it and I teach it to my patients out here when I do some of the group work here. I know my physiotherapists and psychologists use the pain toolkit and that information to spread it to patients there. A lot of my patients are on Facebook chat groups, especially for fibromyalgia and for arthritis, chronic pain, CRPS. So they get that information. They come and tell me, well, I saw this Twitter user who was suggesting this. And I say, fine, this is the advice. This is the evidence. This is why I can't give it or I can say about it. But there's definitely a role for using it. So use it, but I think it needs to be done carefully within the boundaries. That would be my suggestion.
I think that's one thing I always say to people if they see something on the websites or Twitter, Facebook and all that, so make a note of it. But when you see your doctor next or healthcare professional, look, so I've seen this, what do you think?
Yeah.
And so it's about, being a bit wise as well. And I think I saw a paper at the weekend, I can't quite remember, it's not sure if Peter O'Sullivan from Australia, he put it on their post, or someone, I can't remember now, but they
said, the newspaper.
Sorry?
Was it the newspaper article where he was quoted?
Like a research paper where it was saying about how useful social media can be useful for people like me, the patients, etc., learning some different ideas about self-managing their pain. And I think I'm not sure if I've misread it, but it's where we're missing a trick. It's a useful resource, and it's there to be used, really. So.
It is. Oh, definitely. There's so much information on there that it sometimes can confuse the patients there. But as you said rightly, if they can take it, come and ask their GP or their healthcare professional or even a good physiotherapist that they're looking after, what's the deal with this? Can I implement it in my self-management? Can I add it on to what you're offering me? Then it puts the pressure on the healthcare professional also to up his game, to actually do their research, because they don't want to be saying something that's not exactly true. So they're going to do their research, and overall it's going to improve everybody's understanding. And with the new rules on consent, we are absolutely, it's mandatory that users of social media, or for that matter, even in the legal sphere, you're supposed to give the patient all the alternatives, including self-management, and then let them make their decision.
It's funny enough, I come across something caught my eye over the weekend on social media, and it's I think it comes from Australia, where they're using like a wheel. I think the old spider one, I think I called it, spider's web one. And reminded me that I developed something about in 2014 called How Am I Today wheel, I suppose.
Okay.
After we've recorded this, I'll tweet it over to you, may be something useful for your nurses, etc., or you yourself to use with your
Yeah,
patients.
yeah. Do that, do that. I'll tweet it to my physiotherapist as well.
Okay.
And yeah,
Okay. Cool.
absolutely. Thank
Okay.
you.
So we're nearly at the end. So, and to me, this is quite an important question, Deepak, because I've been involved in pain management now, I guess, since, well, I look at it, I don't really look at the days before I went to the pain management program. I think that those are my up and down days, but I know I always say my discovery of learning how to manage myself was started in '96
Yeah.
when I went to the
Mm-hmm.
pain management program, and I can see how much it's improved over the years. And the last question I'll ask you is, how do you see the future of pain management? Not only just for people with pain, but how do you see it with you? How do you see it progressing over the coming months, years, and decades, etc.?
I think with the scale of the problem, for example, in the US, 25% of the population are struggling with chronic pain. I think coming close to 50%, 100 million Americans. In the UK, we've got the data of 28 million UK citizens who are left with persistent pain. The problem is much bigger than even diabetes and stroke and heart attack put together. So it's a massive problem. And with our aging population, that number is only going to increase. But the resources are limited. So I think for any healthcare professional, including myself doing pain management, we need to be clearly aware of how we are going to be relevant and what value we are going to be bringing to the whole kind of transaction, if you were to call it that. So in my place, the Berkshire West, the CCGs, the commissioners themselves have said that they would like pain management to be provided at the forefront. Our whole musculoskeletal service is undergoing a revamp, and they want to make sure that self-management and empowerment of the patient is the first step. And then they've got to have a number of resources in the community closer to the patient to ensure that all these resources are given to them first off. So I think healthcare professionals interested in pain management for the future, next 10, 20 years, have to modify their game to ensure that we can provide to the patients from very close to their home right up into the time when they come for surgery and they're in hospital. I think gone are the days when we could have just been sitting in a hospital waiting for the patient to come to us. We've got to use social media and go out to the patient, maybe do community clinics, work with the physiotherapists and the psychologists and the allied healthcare professionals to find what works for the patient and to see whether we can involve them in the self-management really. And patients have to do the same. They have to take some ownership of the whole thing. They've got to figure out how they play a part. If they're going to say, I'm going to wait for the next surgery or the drug or the injection to sort it out, then they're also going to be on a sticky wicket because that kind of help is not going to be readily available. The way the resources are, especially in the UK, the patients will be made to sort of look at how they are looking after their lifestyle. And I think that's important. We need to put exercise, we need to put healthy lifestyle, we need to put diet, we need to put them at the forefront of it. And once we can ensure that patients are doing that, then we offer them the add-ons at the next step. The biological, it should be the other way. The social should be first, then the psychology, then you bring in the actual biology of the drug. So rather than the biopsychosocial model, it should be the socio-psychobiological model that will be for the future, really. I think as pain and healthcare professionals, what I'm interested in is in how do we screen patients? How do we identify and help patients earlier on so that we give them the right information, give them the right message, give them the right education. Then if they need a particular intervention, bring them into either secondary care or tertiary care to make sure that we do the right thing for the right patient at the right time.
You know, Deepak, I totally agree with you there, and I think for me it's about getting early. And if I had a magic wand, and I mean, the drum I've been banging the last 2 or 3 years is that if we need to slow things down for the future, is to I think we need to start teaching self-management in the schools.
Absolutely.
So that they learn lifelong skills. And
Yeah,
the bonus from that is that they go home and teach their parents, you know.
exactly. Yeah.
That's how I learned a few years ago at an NHS conference. That's how the recycling revolution started. You know, they taught the kids about recycling, the necessity of doing that. And they then went and educate the parents, and they become recyclers. And I think we need to use the same format.
I think so. I mean, the British Pain Society now has got that pain awareness campaign, because we realize we need to go to the grassroots.
Yeah.
I think the Faculty of Pain Medicine has now got this essential pain management, and we've now got a curriculum to actually teach the pre-registration students in university. And you're right. I think the next step needs to go that one level further down, go to the A-level students, go to the school students, and actually give them the basics.
Very small kids,
like you do CPR, you need to be doing it at that level. Exactly. Absolutely.
Deepak, we've done the 5 questions, and I didn't think, you know, you said to me, oh, Pete, I can only do half an hour. And I thought, bloody hell, that's going to be tight. But
I think we got our time management awesomely right. There you go.
You're, you know, there's only one word for you, man. You're awesome. To actually do all that stuff down in 30 minutes, less than 30 minutes. Hats off. So it sounds what you're doing over there in Berkshire. It sounds quite different to what I hear that's going on around other parts of the UK. And I like what you're trying to do there is actually take it out, the pain management out the hospital, stick it in the community where it belongs. Yeah. And I know they use this term called about activating people, but I think it's about reactivating people, because I think what's happened is they've been switched off. Yeah. You know, where they've gone from that being a can-do person, they become a can't-do person, and they're just wandering around the system, draining resources, etc., as I did. So I think what you do,
I think it's natural.
Interesting.
Yeah, it is. I think the iPass service there, we set it up about 2-3 years ago, and I think last year the British Society of Rheumatology, they sort of recognized it as a really good model. They've actually asked us to, funnily enough, they're calling it the toolkit. They want us to make up a proper pain and MSK toolkit, which they then are able to take it and show it to other musculoskeletal services across the country, because they feel that we've got a good model. I think what's worked locally in our area is that our commissioners have been happy with us, and they've asked us to come up. We've been able to collaborate with other stakeholders, and we've been able to do it for the patients in the community. So it's not in the Royal Berkshire Hospital, it's in 3 community areas across a wide geographical area. So that's been nice. There are obviously learnings from 2 years of doing it. We know what to improve, how we can change it. But broadly, it's a good model. And I think, I think we use a lot. Most of my group programs, we use the teachings of the toolkit from there. I think some of the books as well. So I think what you've been doing has been really great, because you've at least given us a template on what an expert patient can do and can take it to a heights which everybody can aspire to. So no, thank you for your work as well.
Listen, I'm not an academic guy. I'm just a normal dude from the street, and I've got no A levels, nothing. And I will say that if I can do it, then I know other people can do it. Deepak, it's been a pleasure to talk to you this afternoon, and thanks very much for taking part in the 5-question, or the Pain Toolkit 5-question interview. And you're very. I think you're brave, because I ask other healthcare professionals, they go, "Oh, what are you going to ask me?" And they start. Oh, for God Almighty! They're just simple questions, man. You know, just relax. Oh, relax. And we have a bit of fun along the way. So,
well, that's the whole thing, isn't it? You try, you fail, you learn again.
Yeah. Okay, so I wish you a good afternoon, and take care, and have a nice sunny summer's evening. Take care now.
Absolutely. Thank you, Pete. Thank you so much.